It's beginning to sound like a broken record that this is the most interesting podcast yet. Insurers and health plans in U.S. healthcare. Employer plans, Medicare Advantage plans. Traditional Medicare has Medicare administrative contractors, the MACs, that handle them, and then Medicaid, states, and all the different companies, and it's all going to mix together. Who has the risk, short-term, long-term, who manages it, and who manages the risk, and who's integral with the individuals that are in the populations. Complicated, isn't it? A detailed study is just too much, but the podcast is going to focus on risk structures and operations. So we're going to bounce quickly through the risk by stakeholder. Individuals have big risk because out of pocket, being uninsured, underinsured, can't get what they need. Employers, we've talked about it all the time. They're in the risk insurance business, and it's a purchasing in the most complicated of ways. The federal government has enormous short and long-term risk, Medicare, Medicaid, VA. We'll talk about it over and over. The 75 trillion, as some people say. And if you look at the demographics of our country, yeah, it's coming at us. And then state and local governments have all sorts of risk, ranging from small community-based hospitals up to running the biggest universities. Health systems, geographic risk, fixed cost mix, and the stakeholder 6. Annual financial performance risk is the main thing. So that's basically where they are. There's pricing risk in here that all shake back across to the left. And there's also the treatment risk that hospitals are always at risk for how they treat people. It's tough. Real long-term risk, it follows the arrows just like that. So there's waste and inefficiency in the healthcare system. It's projected at $1 trillion a year. It's time to do something about it. From the insurer and health plans perspective, it seems like real population health, better healthcare actually works. There's a proven model. And if I'm the stakeholder number 6, an administrator in insurance and health plan, how do I fit in there? First of all, we have to take the step that recognizes where real risks are, how we mitigate those real risks in real population health. And for insurers and health plans, clearly defined roles around administration, defined geographies, defined capital goals, partnerships with the people that deliver care and the people that are actually at risk, and establish goals and performance measures and bring something significant. So that was very fast for insurers and health plans, but it basically comes down to how do we mix administration and risk, short-term risk, long-term risk, and who has real risk, and how do we deliver what individuals need, which is better health care, and lower cost. So it's complex, especially as far as the risk measures. Medicaid and MCOs have unique opportunities and challenges. Medicare, long-term, all the ultimate risk population of healthcare system. Interesting thing that I learned during this process, 2 main players in employer population health, and actually across the board. Blue Cross and United both start with local direct relationships between employers and health systems. It was Baylor and Dallas schools in Dallas for Blue Cross and Physicians Health Plan in Michigan for United. Interesting that they started bottom up. There's a lesson in there somewhere. Thanks for being here.